In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, It's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, It's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships, and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships, and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships, and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, It's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day we work with urgency. We save more than a moment. We save futures, relationships and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, It's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day, we work with urgency. We save more than a moment. We save futures, relationships, and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain, time is unforgiving. A delayed step can mean a lost moment, a lost memory. Yet, every second we save can mean a preserved memory, a steady hand, a brighter future. This is the ripple effect of urgency. Global excellence and innovation in India since 2008. A promise to win where innovation meets the needs of medicine. Every day, we work with urgency. We save more than a moment. We save futures, relationships, and dignity. This is why we act. When time matters, we rise. Because protecting grey matter is not just our mission, it's our life's calling. In the race against diseases of the brain,
a very warm welcome to this Amneal Symposium on Migraine. I'm Dr. Salil Raut with the medical team of Amneal, and it's a pleasure on behalf of our team to invite the eminent faculty that are present here with us for delivering these great talks as well as the panel discussion that we have towards the end. Next slide, please. So today we have with us to chair this session Professor Manmohan Mendiratta. Along with him, Dr. Rahul Kulkarni will be moderating this session towards the end as the part of the panel discussion. We have Dr. Varsha Patil as a panelist along with the other faculty, and we have three speakers with us, Dr. Shripad Pujari, Dr. Vishal Deshpande, and Dr. Mukesh Kumar as a part of this session. Next slide, please. This will be the flow for our symposium today, where we will begin with some context setting by Professor Mendiratta, uh, followed by the role of CGRP in the pathophysiology of migraine, the Empower study, which is the India data, the phase 3 trial on migraine patients, and then followed by the erinumab in chronic migraine, as well as episodic migraine, followed by a panel discussion towards the end. Next slide, please. So it gives us great pleasure to invite Professor Mendiratta as the chairperson for this session on migraine. He's currently the principal director and senior consultant, Department of Neurology at Dr. B.L. Kapoor Hospital, Center for Neurosciences. He's also been an ex-director and professor at GB Pant Institute of Postgraduate Medical Education and Research, as well as the HOD and professor of neurology at the Janakpuri Super Specialty Hospital. He has numerous publications to his name, already published three Cochrane reviews as well, editor in chief of the International Journal of Epilepsy in the past, president of Indian Stroke Association, the APSO, ISN, as well as the board of directors of the World Stroke Organization. Great research as well as teaching experience to his name. It's a pleasure, Professor Mendiratta, to invite you, and we welcome you for your opening comments and to begin the session.
Thank you so much. Thank you. Appreciate. Can you now stop this
Yes.
sharing this presentation?
Yeah.
Okay. Very nice. Thank you so much, Dr. Rao, for the kind introduction and also mentioning about the speakers and the panelists. We have wonderful faculty with us, and we will be soon listening to them. I'll share here that same what you have shown, but question here is that I was very excited to meet my colleagues, Dr. Pujari, Dr. Kulkarni, Dr. Deshpande, Dr. Varsha Patil, Dr. Mukesh Kumar as speaker and as well as the panelists. I'm sure this is going to be very interesting session, and I wish to thank Amneal for organizing this webinar. Now I'll show some slides. I'm a clinical neurologist, though I'm also a researcher, organizer, and other things, but I always believe natural intelligence or clinical is most important, followed by the research application, which should be patient-centric approach. So I'll show only 4 or 5 slides and then go to, I have prepared this for my colleagues. So I hope this is visible. Is it visible, Dr. Salid?
Yes, we can see it.
It is
So
visible.
management of headache, patient-centric approach. So that's what I thought. Ultimately, whatever the monoclonal antibodies or CGRP, these have to be patient-centric approach. Now, this is my brief, what already he has mentioned. So now the citation is around 140,000. I bring greetings from New Delhi, India, what I always prefer to call as Champs-Élysées, like we have in Paris. It's like amazing. Now, headache can be very troublesome. There are migraine days, loss of migraine man days, daily attached to it, and that's why it needs acute management as well as the preventive treatment. Now, a headache is a unique syndrome. I will not touch upon what my colleagues are going to discuss because that will be overlap. Headache is a unique syndrome in medicine and has been termed the most common medical complaint of civilized people or society. Yet, severe headache is only infrequently caused by organic disease. 90% of men look at the burden, and 95% of women have unprovoked headaches annually, one time or the other because of something or the other. Universe, there is not a single human being on this earth who didn't have headache. Universal experience is 1 year period prevalence of 90% and lifetime prevalence of 99%. Sometime or the other, everybody will experience headache. Differential diagnosis of headache is one of the longest in medicine with more than different causes. I'll not cite examples, but we all feel that at times, while taking the history of headache, the treating physician develops headache. I'll tell you one example. One lady came from, then when we asked, since how long you have headache? Sir, it's for last many decades. How many years? When my son was born. When was your son born? He was born on a holy festival day. Now, how will I know when was that holy festival or what? So story goes on, and the treating physician may develop headache, but still it is our responsibility to apply our, what I say, natural intelligence before we head on to artificial intelligence like investigation to diagnose. Although most headaches are benign and still poorly understood the reason, some secondary headache case may have serious underlying causes like subarachnoid hemorrhage. Now, headache history. Now, I have a template in my clinic. I have to ask all these things. Vishal, you can just mute your mic. There's echoing because of that. Temporal profile, age of onset, time to maximum intensity, frequency, time of day, duration, recurrence, headache features, location, and quality of pain. Very important to ask, by which you can make out, is it migraine with aura, without aura, or it is like Sankt or Suna, or it is primary headache or secondary headache. Very important to know. Now, diagnosis, invariably we make from onset, progress, exacerbating relieving factor, associated symptom, very important. What all associated symptoms are there, those are very important. And clinical examination, restricted neck movement will indicate towards that there may be local cause, tenderness may, or deformity may say, spot spine. But this may be radiating to forehead. So it can be headache. Radiological investigations should be selective, patient-centric, and customized, like X-rays, myelogram, CT scan, angiogram, and MRI. But those should not come as first. First is good detailed history. We must devote good time to the patient before we go ahead. So these slides I'll show later. So I'll stop here. Today we are going to discuss about monoclonal antibodies. Now there are newer molecules coming in the market, and we know the impact of these. This is basically because there are still a lot of unmet needs. There are still a lot of unmet needs. Only yesterday we had a advisory board in Bombay on a new GPANT, and there is a need in the society. We go because there are like the earlier one like triptans may not meet what we desire or deserve. So in those situations, that's why aranumab in a very good number of patients with very satisfying results. So with this, I will hand over again to Salim to introduce the next speaker, and Dr. Vishal Deshpande, and then we go ahead with the talks, and later we will have discussion. Thank you so much. Thank you once again, Amneal, for organizing this. Yeah, Dr.
Yes.
Salil, please go ahead.
Thank you so much, Professor Mendiratta. Before we introduce the speakers, I would like to welcome Professor Kulkarni. who is the moderator for the session. Just give me a moment. My screen isn't sharing. Yes. Dr. Kulkarni, very warm welcome to you as a moderator for this session. He's the consultant neurologist at Dinanath Hospital and Research Center in Pune. Uh, More than 30 publications in peer-reviewed journals, member of National International Neurology Associations. He's a principal investigator in numerous multi-center trials in MS, Parkinson's, epilepsy, etc., with extensive teaching experience since 1997. So we look forward, Dr. Kulkarni, for the panel discussion during the moderation. We would now like to welcome our first speaker for the day, Dr. Vishal Deshpande. Dr. Deshpande, sorry, my screen
Yeah,
is
yeah,
acting
I
up.
am. I'm getting you.
Give me a moment. My screen is acting up. I am.
Am I audible right now?
Yes, Dr. Deshpande, a very warm welcome to you for your first talk on role of CGRP. Dr. Deshpande is a consultant at Pune Hospital Research Center with specializations in stroke, epilepsy, and neurocritical care. Multiple papers in peer-reviewed national international journals with contributions to abstracts and academic presentations. He has expertise in acute stroke management, neurointerventions, with invited speakers at several neurology conferences and member of neurology societies. We welcome you, Dr. Deshpande, and over to you for your session on role of CGRP.
Thank you very much, Dr. Salih. Okay, here I will just share the slide now.
Okay.
Is the screen? Are you able to see the screen?
No, we cannot see your slides. Do you want me to share from my end or?
Now,
Yes, it has come up now.
okay.
Can you make it full screen? Can you make it full screen in presentation mode?
It is a full screen now.
In presentation mode.
It is in presentation.
No, for us it is in slideshow mode.
Okay, in presentation mode. Now,
no, we can still see the slides on the side. If you click on the presentation mode at the bottom, it will be a full screen slides.
just a minute. Now,
No, it is still.
Vishal, you have to, on the वो जो स्लाइड साइज है ना उसके जस्ट लेफ्ट साइड में टीवी स्क्रीन का ये है उसको करो देखिए नीचे स्लाइड साइज अरेंज करने
स्लाइड शो, हाँ तो
उसके बाद स्लाइड शो नहीं तो स्लाइड शो ऐसा करो
okay, I'll just skip it anyway.
विशाल
If you click on enable editing, I think that's what they are trying to. The Zoom team is trying to say.
Okay, just a minute. Give me a second. Just a minute, sir. Give me some time. Now,
Yes, now it is in full screen.
okay, sir. So, good evening, everybody. Sorry for being late. Today we'll be discussing about migraine, CGRP, and role of new monoclonal antibodies in migraine treatment. So, as we know that the migraine is a multifactorial etiology. There is a genetic predisposition. There is a role of environment. There is a role of multiple factors which leads to neural as well as vascular activation and which leads to headache. So the key topics in this discussion will be what is the role of CGRP in migraine, or what are the targeted therapies for CGRP, what are the recommendations for the use of CGRP monoclonal antibodies, etc. So, what is CGRP? CGRP is basically a calcitonin gene-related polypeptide. It is a 37 amino acid neuropeptide which is derived from the gene which encode for calcitonin. It's there are many neurotransmitters as well as chemicals and substances which are released in migraine at the neural end, which causes vasodilation and neuroinflammation. One of the strong chemical is CGRP. It is an amino acid which induces vasodilation. There are two forms of CGRP. There is a alpha form, which is a predominant form, and there is a beta form, which is very less prevalent. The alpha form is present in peripheral as well as central nervous system, and the gene is located on the chromosome 11. And the beta form, it is present in the enteric nervous system, and it differs by 3 amino acids from the standard alpha form. Okay. So basically, CGRP is related at the neural ends of the trigeminal nerves and many other nerves. The CGRP receptors are situated in many uh, neural junctions. So why CGRP is important? So because it is released during migraine attacks, so the amount is elevated during episodes of migraine. There is a persistent elevation in chronic migraine as well. CGRP infusion triggers migraine in experimental studies, and the headache relief after sumatriptan coincides with normalization of CGRP levels. And CGRP blockade at key sites is is found effective in many clinical models for the pain. Okay, so such as the blockade at trigeminal cephalic nucleus, the periaqueductal gray matters, the thalamus, and it is found that when we block CGRP, the pain reduces. So here there are uh, multiple diagrams which shows that the nerve terminal releases CGRP, which acts on vessels as well as other neural terminals, and which is involved in activation of other factors as well as vasodilation. So what it does actually, the complex role of CGRP in migraine, the pathophysiology is not completely understood though, but it is involved in multiple processes, both central as well as peripheral nervous system. The main important thing is vasodilation of CGRP related vasodilation. Then it activates the pain receptors, peripheral pain receptors, that is nociceptive activation. It is involved in neurogenic inflammation. It is also involved in cortical spreading depression, and it is also involved in trigeminal sensory activation, which is the central process. So as we know that migraine is basically a complex phenomenon associated with vasodilation and central cortical spreading, which starts from the brainstem, which act and spreads all over. And CGRP is having an important role in all this pathophysiology, though it is not the complete role is not associated, but CGRP is found to be have an association with all these phenomena. So what actually inhibition of CGRP will follow? So where the CGRP receptors are located in both inside as well as outside the blood-brain barrier. So the receptors are found in multiple areas. The important one for migraine is trigeminal ganglion, the cerebral and meningeal vasculature, which is predominantly involved in vasodilation and precipitation of the pain. brainstem, which is involved in activation of the central spreading depression with the trigeminal nucleus, thalamus, which is also involved in the process of migraine. The CGRP receptors are as expressed in numerous cell types: the vascular smooth muscle cells, neurons, the glial cells, and many other patterns, mast cells and glial cells, etc. Okay. So what CGRP and its receptors? The key points are: CGRP is a potent vasodilator in the peripheral and central nervous system. Alpha CGRP is in the predominant form. Experimental and clinical studies support a pivotal role for CGRP and its receptors in migraine. So as we know that CGRP is involved in, it's a potent vasodilator. Along with, there are many other substances. Nitrous oxide is one of the vasodilator. Then substance P is the vasoactive substance. So there is a chemical reaction in between all these episodes. There is PAG related peptides. So that are also involved in vasodilatation. So all these chemicals, they are involved in triggering the migraine. So CGRP binds to the CGRP receptors and they are present in the centrally as well as peripheral nervous system. The localization consists the trigeminal sensitization is involved in migraine pathology. So as we know that CGRP could be a good target. There are many targeted therapies CGRP nowadays. So here are the targeted therapies for CGRP. So what we can do is the anti-CGRP antibodies. So there are multiple antibodies which can target actually the CGRP. These are eptinezumab, the fremanezumab, and galcanezumab. And there are two things: the receptor antibody as well as the receptor antagonist. As we know that the receptor antagonist are all the points, and the receptor antibody, as we are going to discuss today, is irenumab. So all these antagonists and antibodies and antibody to the receptors as well as antibody to the CGRP, they are targeting the CGRP mainly. And the other substance which is involved in neuroinflammation as well as vasodilation is the pituitary adenylate cyclase associated polypeptide. And so this pH and PAC and the chemicals, they also act to initiate the vasodilation and neuroinflammation in migraine. So irenumab is the only molecule targeting CGRP receptor. Other we don't know. There are three antibodies which target CGRP, but receptor is targeted by only irenumab. So the other antibodies, they are targeting the CGRP. They are maps for migraine prevention. As we know, there's eptinezumab, fremanezumab, and galcanezumab. Targeting CGRP receptor potentially provides more migraine-specific action than targeting the CGRP itself, because CGRP binds and activates the CGRP receptors, which in turn initiates many other internal cellular or as well as external cellular movements and secretes many other chemicals which are involved directly or indirectly in vasodilation and cortical spreading depression. So consideration relating to the ligand binding monoclonal antibodies, uh, the consequences of preventing CGRP binding to the other receptors. They decrease the free CGRP in the systemic circulation as well. So now recommendations and guidelines for the use of anti-CGRP monoclonal antibodies. So as we know that the monoclonal antibodies which target CGRP, so they are recommended, the strength of recommendation is in episodic migraine as well as chronic migraine. In episodic migraine, the recommendation is very strong, and in episodic migraine also the recommendation is strong. The quality of evidence we found is kind of high in irenumab, and other antibodies, the evidence is not so good. It is a medium evidence, especially in episodic migraine. Guidelines on the use of anti-CGRP monoclonal antibodies, which patients and are candidates for treatment. So as we know that these antibodies receptor antibodies as well as other monoclonal antibodies are used in episodic migraine and chronic migraine. So patients with two or more preventive medical treatments with inadequate response, so stop oral preventive medication before starting these monoclonal antibodies. And in chronic migraine, so failed treatment with two or more medical agents with inadequate response, we can add or we can shift the patient to these monoclonal antibodies, and we can later withdraw the oral medication. Evidence for ianalumab treatment in episodic migraine. So there are two trials. One is ARISE trial and one is STRIVE trial. The ARISE trial shows the significant reduction in monthly migraine days with 3 months of treatment, where the study was conducted for a total 52 weeks, and 12 weeks they had given this ianalumab 70 uh, mcg 70 mg subcutaneously once in a IV once in a month. And they found that after the trial there was overall 50% reduction in monthly migraine days, which was achieved by almost 40%, and the placebo showed only 30%. So the p-value was very significant. So the change from baseline monthly migraine days was very significant while using ianalumab. The STRIVE trial also expected this experienced the same, and the it showed that the reduction in monthly migraine days was reduced by 50% compared to the placebo. So it was effective in patients who had failed on two or more prophylactic agents used for migraine, and it is significantly, the p-value is significant while detecting the efficacy. At 12 weeks, 30% of ianalumab group trial had a 50% or more reduction in monthly number of migraine days as compared to 40% only in the placebo group. So now this was for the episodic migraine. Now in chronic migraine, the study is showing that it is effective in ianalumab. It reduces the monthly migraine days by significant in significant number of patients, and but it is more predominant in episodic migraine as we had seen earlier. So the overall patients enrolled in this study had shown that the mean monthly reduction in the migraine days during the baseline phase was significant. So as we can see the graph of placebo and the ianalumab, so it is showing that the ianalumab 70 mg and ianalumab 140 mg, so it is almost the same. The monthly reduction is almost the same from baseline. So the dose, if you change, it is almost the same. So overall, half of the patients in chronic migraine were able to stop overusing acute medications while the use of ianalumab. Long-term benefits of ianalumab treatment. So the reduction in monthly migraine days and improved quality of life with extended treatment in responders. So the open label 5-year treatment phase is going on following the 12 weeks trial, and in adults with episodic migraine, patient initially received open label 70 mg of ianalumab, which then gradually increased to 140 after a protocol amendment. So we will see shortly how the studies of long-term treatment of ianalumab is going to reduce the migraine burden or the migraine days, monthly migraine days, headaches. The continued treatment showed sustained reduction in acute migraine specific medication days. Among the patients, you are using the baseline uh, treatment of 21 mg, and the mean change from the baseline was a few days. So it is showing that the patients initially received 70 mg, which is increased to 140 mg of protocol amendment. So it's almost showing that there is a significant reduction in the headache days, even if it is given for prolonged time. The long-term data is highlighted the improved patient-reported outcomes in terms of migraine impact and disability, but we still need to know the efficacy, so safety profile of this agent. So that's why the long-term data is still not available. So safety profile, it is showed that the adverse effect leading to discontinuation of iranomab was less in patients. Those the other those uh, of only 400 patients who received more than one dose of iranomab, the binding antibodies were developed in 39 patients. So there were development of antibodies as well. So there was no evidence of association between anti-iranomab antibodies and safety events. So as we know, it has established and consistent safety and tolerability profile. So giving the conclusion, it has played an important role in migraine pathophysiology CGRP, and inhibiting the CGRP is key target for the prophylaxis of migraine. The use of anti-CGRP monoclonal antibodies is recommended in both episodic as well as chronic migraine. It has shown efficacy across the spectrum of migraine patient, including chronic migraine, iranomab, and medication overuse, episodic migraine, and patients who have failed multiple other prophylactic agents. Benefits of iranomab has sustained over long time treatment, and it has well established safety profile with 5 years of evidence showing no safety concerns. Thank you.
Thank you so much, Dr. Vishal Deshpande. It was very informative talk, and I'm hopeful that during panel discussion we'll have much more interesting questions. And I agree with you. We are also using 70 milligram every 4 weeks subcutaneously, usually given in the abdomen, and found to be quite helpful. So I'll just show that next speaker will be Dr. Mukesh Kumar. Salil, would you like to? Okay, I'll introduce. Dr. Mukesh Kumar is Director and Head Parkinson Disease Unit, MAP Super Specialty Hospital, Saket, New Delhi. We are working in the same healthcare group that Max Healthcare. Had the chance to meet Mukesh few times. And he has published articles in peer-reviewed journals, member editorial board, Annals of Indian Academy of Neurology, contributor to Neurology Textbooks and CME, and major Inspiring Neurologist Award, Best Innovative Teacher Award, Iconic Healthcare Leader Award, MS Signature Award, and guided multiple neurology theses, active registry, and clinical research initiatives. And he is going to speak on the study, which again will highlight the importance of monoclonal antibody, that is EMPOWER study. I'll invite Dr. Mukesh Kumar to present this important study. Dr. Mukesh Kumar. Dr. Mukesh Kumar, are you around? Yeah, unmute yourself, Mukesh. Please unmute yourself. You are muted, Dr. Mukesh.
Yes, sir.
Very good, very good, very good. Yeah.
Yes, sir. So, good evening, everybody. Thanks for giving this opportunity to discuss about adalimumab. I have started using adalimumab in 2020, and after that, I am regular. And so good medicine that if someone can afford it, is one of the best thing. Okay, let's go further. Next slide. Next. So, Erinumab is almost established efficacy and safety in all global trials, and safety is almost 100%. No major side effect I have seen in last 5 years. Next slide. The overview in EM pivotal trials, there is a Strive 6 AMO EM study. It is episodic migraine 6-month study, which is significant reduction in monthly migraine days from baseline to 4 to 6 months compared to placebo. So it is almost 70 milligram and 140 milligram. There is some difference, but 70 milligram is definitely better than placebo. In Liberty episodic migraine patient with prior prophylactic failure, there is a significant higher proportion of patients with 50% reduction in monthly migraine days. And 5-year data in episodic migraine is that it is more than 50% response and more than 100% response in 36.3% cases over a period of 5 years. Next slide. So what is the Indian experience? The Indian experience is a 12-week double-blind randomized multi-center study comparing the efficacy and safety of monthly subcutaneous adalimumab against placebo. And this is termed as adult episodic migraine patient, that is empowered, a subset analysis from the global study. So study-wise, total 27 sites and 900 subject, and Indian case is 351 subject, and which is almost 40%. Primary objective is to evaluate the effect of adalimumab compared to placebo on the change from baseline in monthly migraine days. And secondly, objective is to evaluate the effect of adalimumab compared to placebo in the proportion of subject with at least 50% reduction from baseline in monthly migraine days. And headache impact score as measured by headache impact test, and evaluate the safety and tolerability of adalimumab. So it is divided into two groups: adalimumab 70 milligram, adalimumab for 140 milligram compared to placebo 330. So placebo is 330, adalimumab 70 milligram is 330 pin numbers, and 140 milligram is 220 cases. So that is randomized after 2 weeks of screening and 4 weeks of baseline, and then double blind treatment for 12 weeks and follow for another 12 weeks. So among demographics, Indian subpopulation, out of 354 cases, 17 are male, 83% are female. And average migraine day is 23 male and 102 females for 70 milligram. And for placebo, it is again 21% male and 78% female. All subject is total is 21% male and 79% female. Next. Baseline disease characteristic monthly migraine days for adalimumab placebo is 124. For 70 milligram adalimumab group, it is 133. And for 140 milligram adalimumab group is 94. So monthly particular days is on all subjects is 351. Next slide. So what is the results? So if you see at each dose and at the end of 3 months, average migraine effect in with second slide point, it is reduced to 4.2 days and 4.79 days in 170 milligram and 140 milligram groups, and that is 3.1 days in placebo groups. So there is a numerically high reduction in monthly migraine days in both adalimumab dose group, both 70 milligram and 140 milligram compared to placebo. Next slide. So a statistically significant more proportion of patients achieve 50% reduction in monthly migraine days, and numerically higher proportion of patients achieved a 50% reduction in monthly migraine in Indian result, which is 59% in 70 milligram and 58% in with 140 milligram dose. Next slide. So headache impact score is global result is minus 8.39 compared to placebo, while 70 milligram in Indian result is minus 9.65. And adalimumab 140 milligram is almost same, both global and Indian results. Next slide. Overall safety profile is well tolerated, and serious event were similar between the one adverse event and serious event were similar between the groups. 9.6% receiving placebo, 11.3% receiving adalimumab, and 10.7% receiving adalimumab 140 milligram experiencing treatment-related adverse event. And most common adverse event are constipation, nasopharyngitis, dizziness, and pyrexia. No death and no adverse related discontinuation is reported. Next slide. So in Indian profile, overall safety-wise compared with no new safety signals. Nasophonitis constipation of cough and pyrexia is most common in less than 6% success subject, and pain was reported in less than 1% subject. No subject discontinued the study because of the adverse event. So in change in diastolic and systolic blood pressure, that's in sitting systolic and pressure low or high or higher in the placebo group and compared with adalimumab, which is 7.8% in 70 milligram and 5.4% in 140 milligram. However, elevated systolic and diastolic blood pressures were higher in both adalimumab group compared to with placebo, but no discontinuation because of this side effect. Next slide. So key message is that adalimumab is safe and effective preventive treatment. Side effect like nasopharyngitis, pyrexia, and body pain is tolerable side effect, and no serious adverse event leading to discontinuation, and no death, and no major side effects reported. So similar to other placebo control group, both dose of adalimumab was significantly improves all measures of patient-reported outcome in the global trial. And it is not powered to evaluate the efficacy of adalimumab in the Indian population, but efficacy and safety profile shows improvement numerically for relevant endpoint versus placebo, thus consistent with the global study population. So in summary, adalimumab is one of the time-tested molecule, and it is one of the if affordable and if then it is one of the acceptable molecule for the treatment of the migraine, both episodic as well as chronic migraine. Thank you.
Thank you, Dr. Mukesh Kumar Adak.
Sir.
Again, emphasizing the point that this is a very good molecule, helpful in episodic as well as chronic migraine. And 70 milligram is the right dose, as effective as 140 milligram, with very few side effects, which are mild and manageable. So, wonderful talk, Dr. Mukesh.
Thank you, sir.
We'll go on to the next speaker, Dr. Siripat Pujari. We recently met in one of the meetings, and very pleasant person. He is working at Dinanath Hospital, Pune, Noble Hospital, Pune. He has special interest in stroke, epilepsy, and neuromuscular disorders. We all are clinical neurologists with special interest in certain aspects because in India we are few and we have to look after the patient. Major achievements, multiple publications in peer-reviewed national and international journals, author of chapters in textbooks, speaker and presenter at national international neurology conferences, extensive experience. Dr. Mukesh, you can mute your mic here. Experience in acute stroke care and neurocritical care, invited faculty at important neurology and stroke workshops. So he conducted a very successful meeting in Pune, and I learned a lot during that presentation. And now I invite Dr. Siripat Pujari. Again, he would be speaking on role of monoclonal antibodies in episodic migraine and chronic migraine. Dr. Pujari, please.
Yeah. Can I share my thank you very much, Professor Mendiratta, this kind introduction. And thank you, Amneal, for giving me the opportunity. Can I share my slide, please?
Yes, Dr. Pujari, I've stopped sharing. You can take over.
Yeah.
Yeah, coming very well. Coming very well.
Yeah. Yeah. Yes, good evening, everybody. Thank you again, and Dr. Deshpande and Dr. Mukesh has already set the stage. They've already prepared you to understand about role of erenumab in both episodic and chronic migraine. I have been given the role of giving you the data, first-hand data on the pivotal and important trials conducted for both episodic as well as chronic migraine. So here I start. So as I said, we will have a bit of overview on migraine, followed by evidence about erenumab in episodic migraine, and then I'll proceed to the after the conclusions to the chronic migraine. So we all know the definition of episodic migraine: fewer than 15 migraine days or headache per month. But we also know that none of the presently licensed medicines such as antihypertensives, antiepileptics, antidepressants are specifically directed towards the basic pathogenesis of migraine. Erenumab was the first CGRP receptor monoclonal antibody directed against both episodic as well as chronic migraine. And Dr. Deshpande has already said this actually is available as a 70 milligram per ml solution. The dose frequency is once a month subcutaneously, and it can be used that infrequently because of its long half-life. Before I move on to the trials itself, again remember with acute drugs for migraine, you look for 2-hour pain freedom and freedom from most bothersome symptoms. And with prevention studies, you look for reduction in mean monthly migraine days, more than 50% reduction in the same, and migraine specific medication use days should get reduced, and improvement in several disability assessment scores. So with that, I come to the first pivotal STRIVE study, which was a multi-center placebo-controlled tested for the prevention of episodic migraine. And as you can see the flow chart, it began with a double-blind phase followed by an active treatment phase including both dosage groups. And look at the demographics. They were equal for both placebo and the dosages, which included the migraine days per month, the migraine specific medication use, and with results it showed a significant reduction in monthly migraine days. The navy blue is placebo, the cobalt blue and the sky blue are 70 milligram and 140 milligram. Same here, there was significant improvement in more than 50% reduction in MMDs and significant reduction in use of acute medication as well, as you can see here with my pointer. And the drug had an early onset of action, reducing the migraine frequency after weeks of treatment. And it also significantly improved the patient quality of life measures as measured by several migraine related specific questionnaires as well as migraine physical function impact diary. As far as safety was concerned, it was comparable. There was no difference between as compared with placebo in liver, renal function, neutrophil counts, vital signs and ECG. The next important ARISE study, again 69 sites as you can see. Again the flowchart showing comparison and beginning as double blind and moving on to the active treatment phase and a safety follow-up for more than 12 weeks. Again similar demographics as far as the migraine days, migraine specific migraine specific acute drug use. And as you can see, significant reduction in MMDs, significant reduction in more than 50% MMDs, and it significantly improved the everyday activity and physical function with the standard MPFID scores. And it again, this second trial also reiterated on its comparable safety with placebo. And the third very important Liberty study, again, this time it was used in episodic migraine in whom previous treatment with migraine preventives had been unsuccessful. Let's look at the flow chart. Again, there's a placebo versus control phase, and a similar demographics in terms of monthly migraine days and acute headache medicine use, as you can see here, highlighted in red. In this trial as well, it increased the proportion of episodic migraine patients achieving more than 50% reduction in MMDs, even following 2 to 4 previously prophylactic treatment failures. So, in this trial showed that erenumab successfully fulfilled all the secondary endpoints as I have listed: MMDs, MSMDs, the quality of life questionnaires, and more than 75% reduction in monthly migraine days, even up to the week 12. It was again no problem with safety even in the Liberty trial, and so we can now say with confidence that it has a meaningful response with reduction in MMDs, more than 50% responder rate, and reduction in acute migraine specific medicine. It is safe, and it improved not just the neurologist assessed outcomes, but also patient reported functional outcomes. And there is now very robust and strong evidence for a novel CGRP receptor directed therapy. With this, now I move on to the second part of my lecture, which is prevention in chronic migraine. Again, this part is divided into overview, followed by its evidence in its first pivotal study, followed by subset analysis in previous treatment failure patients, and then its impact on patient reported quality of life. So, we all know chronic migraine is at least 15 headache days per month, of which 8 or more should be with or without aura, and it's a very common entity affecting up to 2% of the global population and most prevalent type of headache in tertiary care. Let's look at the pivotal trial for chronic migraine. A randomized double-blind controlled phase 2 trial assessing both dosages in multiple countries, and the flowchart, as you can see, which was a double-blind phase followed by an open extension for a staggering up to 52 weeks. Again, comparable demographics highlighted in red in terms of monthly migraine days, monthly acute migraine specific medication use. Here you are. And the same colors again for placebo, navy blue, and cobalt blue and sky blue for the 2 dosages of erenumab. And you can see a significant reduction. See the gap here in monthly migraine days. Even now for chronic migraine, significant proportion of patients achieving 50% reduction in MMDs, significantly reduced use of migraine specific medicines, and a comparable safety profile. You can see the numbers here in terms of upper respiratory injection site pain, nasopharyngitis, and many other side effects is around the same, both comparing placebo with lower and higher doses of erenumab. Moving to the subset analysis in those who have failed with previous treatments. Until then, there was not much of a data, but this subset study has now assessed that efficacy of erenumab in patients who had previously failed preventive medicines. It was more than 1 or more than 2. And look at the numbers here. The numbers were comparable in terms of the ones. There was a 3-2-2. So there were comparable numbers with 70 and 140 milligrams against the placebo. And look at the list of drugs. All drugs have been included which includes antihypertensives, anti-epileptics, tricyclic antidepressants, SNRIs, and botulinum toxin. And look at the numbers here. The baseline demographics, as you can see, are the same. The age is same. The proportion of patients who the ratio of female to male is similar, and the disease duration are also similar in all three groups. Yeah, and the monthly migraine days, use of MSM, and monthly migraine specific migraine medicine days are again the same. Look at the numbers there. The number here around 80 to 85, 88%, and 10 to 12.4. So it was effective in reducing the MMDs in chronic patients with prior treatment failure. Look at the gap between the two graphs. And the evidence was true with one or more and even more than two prior treatment failures. And it was able to significantly reduce the migraine specific medicine usage. And so much importance is patient reported quality of life. So it was assessed with the HIT6 questionnaire, where again there was a significant effect, and so with reduced absenteeism and attending their own workplace. Yeah, and they were able also, it also significantly improved the ability of patients to go about with their daily lives. And so was with the PROMIS, that is the patient reported outcomes from baseline. As you can see the gap in the graph. So we can definitely conclude very strongly that erenumab is superior in terms of efficacy as measured by MMDs, more than 50% responded, a reduction in acute migraine specific medicine, and they were seen regardless of previous treatment failure. And it also impacts the drug has an impact on migraine, improving the quality of life and allows them to better go about in their daily routine work, and it is well tolerated with good safety. Thank you very much. I think that is where I end my lecture, wherein I have covered all the evidence in both types of migraine, and I'll stop sharing now.
Thank you so much, Shripat, again emphasizing the point, usefulness of this monoclonal chimeric antibodies for prevention of migraine, whether episodic or whether it's chronic migraine. We know that 25% of women suffer from this migraine and 8% of men. And DALI is very high when you see the GBD, Global Burden of Disease analysis, and headache is one of the very important symptoms in the civilized society. I think now is the time to hand over the mic to the boss, Dr. Rahul Kulkarni, who has established his name at national and international level. And Rahul, please carry on with the moderation, question answers from the experts. Please first introduce Dr. Varsha, that I think have been introduced. Dr. Rahul, please. Rahulji, unmute your mic.
Yes, sir. Thank you, sir. Thank you very much. Thanks for inviting me. So I would like to invite Dr. Varsha. Dr. Varsha Patil, she is a consultant neurologist at Bombay Hospital, and she's been in teaching for last 12 years. She had many publications, and she is also section editor of 5 minutes clinical neurology and multiple sclerosis, 5-minute clinical consult, as well as MS textbook chapters. And we all know that she was topper in the MUHS DM examination. So welcome, Varsha. So what we do is
Thank you, sir.
Thank you, Varsha. So what we have is now, Salil, do we directly go to the questions?
Yes, Dr. Kulkarni, if you have any thoughts or comments about the lectures, and then it's over to you for the panel discussion.
Yes. So maybe what we will have a couple of questions to all three panelists, Dr. Shripat Pujari, Dr. Mukesh, Dr. Varsha, as well as Dr. Vishal. So maybe if we can start with Varsha, because you're the only one who had not spoken probably. So you can tell me something about your experience about chronic migraine. How frequently you see chronic migraine? What is your idea about the therapies of those chronic migraine, and how many of them are really refractory to the conventional, orals which we have been using since our college days?
Dr. Rahul,
Yes, sir.
one is focus your camera, your face is half visible
Sorry,
because
sir. I'll just.
we need full face like we need for the passport
Okay, sir.
or getting the visa that way and make it landscape. If you look like you are, yeah, now it's nice. Nice.
Okay. Thank
You
you.
are in a nice, beautiful kurta, looking very nice.
Thank you, sir.
Yeah.
Thank you.
Yeah.
Thank you for the kind introduction, sir. And we have seniors, experts, and everybody in the panel here. Well, we know, sir, that migraine is so common in the outpatient that if we had to really not over ratify it, but say that at least 8 out of 10 people who came with headaches were really migraines if we took it in the OPD. So chronic migraine as such is a big part, a big chunk of these migraine years. If we keep digging into the history, sir, then a lot of them do qualify. Like Pendiratta sir said, that sometimes, these women who come, they don't even bother to tell us what is the timeline of how many years they may have suffered from migraine. And if you keep digging into it, then you realize, हाँ ये headache तो बहुत सालों से है. अब ये थोड़ा सा और बढ़ गया है. So this is how they really try to say it out. And sir, as regards to the therapies, I would say erinumab is one of the newer innovations that come in. But honestly, if you ask me, that's not the first drug that I'm going to give the patients. So I would still go by the old school and give the acute symptomatic treatments and the other treatments, the orals for the treatment of migraines. Namely, sir, the topiramate or the flunarizine or your beta blockers, depending upon what is the type of patient, what is the type of comorbidities that they have, and what kind of work profile the patient has. So, for example, of course, when I start them, I am a little reluctant to start valproate or divalproate as a chronic migraine therapy, especially in females. And so, topiramate, I'm a little careful, but because there has been a patient instance who was started on migraine treatment, topiramate, and had an acute angle closure glaucoma. So, I'm a little worried, and I do warn them about these symptoms before I start any of the therapies. Thank you, sir.
Okay, thanks, Dr. Varsha. Maybe Shripad, if you can say something about what is the unmet need of the current standard of care that we're using, if you can tell something on this. The current medicine, the orals which we're using, what is the unmet need? I mean, what are the limitation of these drugs?
Yes, I think Dr. Varsha has already pointed out few. So far as far as the preventive medicines are concerned, as I said, displayed in one of the slides, that none of the medicines originally was, discovered for migraine. All of this are either antihypertensives, anti-epileptics, or drugs for use for other causes, and then they were repurposed or sort of found that they act on one or the other mechanisms. Although the concept and our understanding of the basic pathogenesis of migraine has evolved, and now we no more harp on the old theories of vasodilatation, vasoconstriction, and spreading wave depression. Those were the theories based on which drugs like calcium channel blockers, beta blockers, and topiramate were based on. And then we've evolved now to understand at basic neurotransmitter level and very important mechanism through CGRP, which we just heard. And all these CGRP addressing molecules, I feel, are the one that are prima facie discovered, tried and tested well through, like I showed in phase 3, and now when phase 4 or open label data, that that they are effective with good safety profile, and they should become the future of migraine therapy.
Okay, thank you. Mukesh, if you can say something about what is your definition of failure of a medicines, the prophylactic, if you can speak something. Dr. Mukesh, if you're there. Dr. Mukesh, Dr. Vishal, are you there?
Yes, I am there.
So Mukesh, if you can say something about what is your idea about failure of a medicine, the prophylactic one.
So Dr. Mukesh is not there. I'll go through it.
Shall you can answer. What do you think if you are using an oral medicine? What is our definition of failure of a
Persistent of the symptoms in spite of giving adequate oral treatment or two or more medications, and if there is no reduction of the number of migraine days per month, as well as if with the help of medications, if it is producing side effect, we can say that it is a failure of treatment.
Okay, so Varsha, will you use CGRP molecules? If you have to use, where will you use in your practice?
I have been using CGRP receptor antibodies, and there has been a selected cohort that I use. As I mentioned first, I have never used it in a treatment naive patient. Those who have failed at least 2 to 3 chronic therapy medications have been having severe migraine attacks or have had more migraine days per month, like Pujari sir had said. And in those patients who are more than 18 years of age, there was a question where, there was a 15, 16-year-old who had very severe migraine and not responding to 3, 4 drugs, but I couldn't because the FDA label says more than 18 years.
Okay.
So, sir, also, I have used it in patients who have failed botulinum toxin injections for the chronic migraines. And in that patient, particularly that patient, sir, she had absolutely marvelous response to the CGRP receptor. So much so that she would say that whenever I went out for a family function, it was a disaster for me because whenever those sounds and lights came in, my migraines were bound to go away, blow up completely. And with the CGRP, the erinumab 70 milligram, at least 3 to 4 doses, she has been able to go and attend family functions. It has been that helpful for her.
Okay. And what are the common side effects that you have observed with erinumab?
So, really speaking, not much. A little bit of injection site pain, and one patient complained of constipation. No other real side effects that I noticed.
Okay, thank you. So Shripad, if you have to really use it, how many days will you give a trial to say that whether it is working or not? And then what is the longest duration that you'd use this molecule?
I've used it in 2 patients so far. The minimum duration I would say is 3 months. Before we consider it's either it is showing its efficacy or not. The maximum I have used is 6 months, really, no more than that so far.
So, if I may add on this point,
Please.
usually there are those who have some expectations saying एक dose से अच्छा हो जाएगा. So then I usually tell them 3 doses will be required before you say that it has worked or not worked. And beyond 6, our patient really talk about the cost, sir, because then they are better at that particular point of time. And though the studies and data mentions, but sir, I don't know, would it be cost effective to continue it for so longer than 6 months?
So there are patients who are, especially the chronic migraines, who are continued for a long period. So maybe Vishal, if I can ask you, as what will you say that when you are starting the drug, what will be your idea that this drug has really worked or not? I mean, will it be complete 100% migraine reduction or 50%? What will you say when you are using this kind of drug?
If the patient is showing more than 50% of reduction of his symptoms or migraine days, then I think probably it is more than what we can achieve with the medical agents or the other drugs which we are using traditionally. So along
I think it's got disconnected.
Yeah. So yeah. So anyone else would like to comment anything? I have used in some of my patients, especially I'll be happiest if I use it in chronic migraineurs, where this really helps us to break the cycle of chronic, bring them back to the episodic one. So that's one best indication where I would use it. And of course, those refractory who are taken 7, 8, 5, 6 different kind of medicine, those are patients where you use it. I don't know whether one would use this as a first line agent because of the cost issue, but yes, we see that in the Western countries, they are moving more towards CGRPs. So they inject CGRP monthly or maybe once every 3 months and give a GPANT as an SOS therapy. That's where the world is moving. I don't know whether this will be situation in India after a few years. Maybe by the time the next batch of neurologists come in, maybe that may be the way the world would move ahead. So Mendiratta sir, would you like to say anything?
I would like to just say one sentence. I would also use in those patients where sometimes the headache goes away with other preventives, but the most bothersome symptoms are more distressing, where our previous category of medicines do not help those much.
Okay.
Yeah, Dr. Rahul, the principal aim of this, what I said, chimeric monoclonal antibody is to prevent migraine attacks. Now, comes for acute symptomatic relief, we know first line, second line, and there are G plans now, which are for acute and chronic both. Chronic episodic as well as the chronic migraine prevention. So acute attack and prevention. So the point on which this is dealt for acute pain is relief of pain within 2 hours. How many you are relieved within 2 hours? And other bothersome symptoms of migraine, MDS. So from that point of view, what I use is basically I will give them something for prevention of NSAID or a cup of coffee or maybe paracetamol, whatever gives them relief, and also stay away from the photosensitivity and also from the noise. So in a dark room, those things, and local head massage, what are conventional methods? And then Ranibizumab, as has been mentioned, usually even in prophylaxis, I say the effect may come after 4 to 6 weeks. Similarly, for this, we have to have at least 2 to 3 injections, but often to maintain a migraine diary. Because they will say headache is same. Now frequency may be same, but duration has come down, severity has come down. So on that scale, VAS, visual analog scale or something, they should be told that you have to maintain a diary and then bring the diary to me. Number of episodes, severity and intensity is very, very important to understand. And the beautiful part about this monoclonal antibody is that if out of pocket, I know it costs around, maybe around different 25,000 rupees or so, but it's approved in CGHS. So I run a day for CGHS on every Tuesday in my clinic, OPD, and we see good number of patients who, it takes little time, but they bring this, we write for 6 months. I write for 6 months, that every 4 weeks or every month, injection to be given subcutaneously with pre-filled syringe, 70 milligrams for 6 months. So then they get a stock. And then when it is reserved, then we go on regular basis. Yeah, Rahulji, you are muted, Rahul.
Sorry, sir. No, please go on, sir. Sorry.
That's what the way we do the practice. And there are people, I have treated people coming from Mongolia, people coming from a Dr. Hassel, a pediatrician coming from Siliguri, and a good number of patients in New Delhi and neighboring states. And we can say that we have not done any randomized controlled trial because these have already been done. So prospectively, most of the patients are happy. I will say if that goes 8 out of 10, approximately what I've treated are very happy and satisfied, as Dr. Varsha also said, with this molecule. And after 6 months, I definitely, but in that time, I also continue other, suppose I'm giving prophylactic like beta blocker, which is the only one which is actually approved as compared to many others, or in status epilepticus, valproate, or topiramate in those who have migraine and who have obesity. So in those patients. So I will continue that, and as the response comes, then I keep reducing. With the oral, I will always say, give me at least 1 year. You have this headache for last 10 years. Give me at least 1 year to see that it shows good results. These are the practical, which I'm saying from my point of view. I may not be correct in certain aspects, but correct me if I'm wrong somewhere. Thank you. Siripas, you
So,
were
yes,
saying something.
Siripas, completely agree, sir.
Siripas, you were saying something. You are muted.
No, completely agree with you, sir. Completely
Thank
agree.
you. Thank you.
So in the trials, when the patients were included, those who had episodic migraine, they were given just the monotherapy. And in the chronic migraine, patients were on orals plus then they were given additional this. But in the clinical practice, it is very hard to stop the oral that patient is taking when we start the new treatment. Only when the attacks go down, then probably we would start reducing the oral prophylactic therapies, and then maybe patient could go on monotherapy. So switching immediately to monotherapy in a patient who has been taking orals for months or years together will be a bit difficult thing in the practice, usually in day-to-day practice.
In practical, I give
he may
adjuvant.
require a bit of prophylaxis later also.
Yeah, I give
After we
adjuvant.
stop the Erenumab.
Yes. Because after you have stopped it, it may reduce the frequency, intensity, and severity. But then again, suppose it bounces back. So maybe the most tolerable dose, not very high dose. Beta blockers we hardly use in our practice. I've seen all over India, 80 milligrams, or sometimes maybe 160. While in the Western countries, they go up to 320 milligrams. So we per se are using lower dose than that. And as Dr. Vatsha rightly mentioned, in adolescent group, childbearing age group, we tend to avoid valproate. Thank you.
Thank you, sir. So anyone would like to comment before we just hand it over back to the Amneal people, Dr. Salil?
Dr. Vatsha, any other your thoughtful comments? Dr. Vatsha?
Most of it is covered. I mean, rather we enrich from your experience, which is so vast. But I resonate the same thing, sir. In selected group of patients, I've seen really good results. And safety-wise, it's been quite bad, easy. Because, when they say MABs, people talk about immunity going down because the other MABs are there. And so we have to emphasize to them that the immunity will not be affected because it's a totally different pathway.
Yeah, I often emphasize that the gold standard is history. Headache is not visible, and try to listen to the patient with patience. So, for the patient needs patience because they start showing MRIs and other things. I'll not go on concluding remarks because that got some slides. The other is even we doctors need a lot of patience to understand the pain of patients.
Absolutely.
Thank you, sir. So thank you everyone for an active participation, good discussion, and good comments by Mendiratta sir about the practical tips. So thank you everyone. Thank you Vishal. Thank you Dr. Mukesh. Thank you Dr. Varsha. Thank you Dr. Shripad. And thank you sir for being here. So over back to the Amneal people, Dr. Salil.
Thank you so much, Dr. Kulkarni. And thank you to all the faculty, especially Professor Mendiratta, for sharing your rich experience. Thank you, Dr. Pujari, Dr. Patil, Dr. Deshpande, and Dr. Mukesh Kumar for your valuable insights. On behalf of our team at Amneal, we really express our gratitude to this panel. And thank you for the audience members for joining.
Thank you so much.
Have a wonderful evening, everyone.
Thank
Good
you.
night. Good night, sir.
Good night.
Thank you, sir. Good night, everyone.
Night.
Bye.
Good night.
Good night. Vatsha. Good night.
Thank you, Vishal and team. Thank you. Thank you.
Thank you, team. Bye-bye.
Thank you, Dr. Salil. Thank you.
Thanks, Bharat. Bye.
Recording stopped.